Welcome to this deep dive. Today, we are taking you into the fascinating and honestly incredibly complex world of inflammatory bowel disease pharmacology.
Yeah, it is a massive topic.
It really is. We've got this huge stack of sources in front of us today. I mean, everything from these wild historical medical anecdotes from the 1930s all the way up to cutting-edge clinical trial data.
And the mission here is to sort of decode how all of this information reveals the evolution of treating Crohn's disease and ulcerative colitis.
Exactly. We're going to explore how we went from, basically accidental discoveries to engineering these molecules that can literally rewire the human immune system.
It's a remarkable evolution. But to really grasp the science of these drugs, we first need to establish the baseline of what we're actually treating here.
Right, because we throw around acronyms a lot.
Yeah. So when we talk about inflammatory bowel disease, or IBD, we are dealing with two major chronic, relapsing, remitting autoimmune conditions. That's ulcerative colitis and Crohn's disease.
And these are conditions where the body's own immune system essentially goes rogue, right? It just attacks the gastrointestinal tract.
Exactly. It's an autoimmune attack.
Okay, let's unpack this a bit to anchor it in the underlying pathology. Because I know anyone following the space knows it's fundamentally different from something like IBS, which is irritable bowel syndrome.
Oh, yeah. That's a huge misconception. People confuse IBD and IBS all the time.
They sound so similar, but a helpful way to visualize the baseline difference is to think about a house.
Okay, I like this analogy.
So IBS is like having a functional plumbing issue in the house. The pipes might make terrible noises, the sinks might back up. I mean, the symptoms are very real for the patient, but structurally, the house itself is completely intact.
Right, there's no actual damage to the walls.
Exactly. But IBD, on the other hand, is the house actively being on fire. There is measurable, visible tissue destruction happening inside.
That framing is crucial, really, for understanding the pharmacology. Because the drugs we're analyzing today, they are heavy-duty fire extinguishers designed for that structural fire.
They don't just fix the plumbing?
No, they do absolutely nothing for a functional plumbing issue. And within that burning house, the two main conditions actually behave pretty differently.
Right, ulcerative colitis versus Crohn's.
Yeah. So ulcerative colitis involves a continuous layer of inflammation, but it is strictly limited to the colon, the large intestine. It burns that superficial mucosal layer.
Whereas Crohn's is sort of all over the place.
Crohn's disease is much more unpredictable. It can strike anywhere along the entire digestive tract, literally from the mouth to the anus.
Wow, anywhere.
Anywhere. And it creates what are called skip lesions, which are these areas of intense inflammation sitting right next to perfectly healthy tissue. Plus, it burns deep, penetrating through the entire thickness of the bowel wall.
Okay, so treating those two distinct patterns obviously requires entirely different tools. But looking through the clinical history, what really stands out is how the entire medical definition of a successful tool has completely shifted over the last couple of decades.
Oh, absolutely. The paradigm has completely flipped.
Because the old benchmark used to just be pure symptom control, right? Like if a patient said their stomach stopped hurting, doctors were like, great, the drug is working.
Yeah, the historical approach was entirely subjective, which, as it turns out, was incredibly dangerous for long-term patient outcomes.
Because the fire wasn't actually out.
Exactly. Over the last 20 years or so, trial data just consistently showed this troubling pattern. A patient could report feeling perfectly fine, their clinical symptoms might totally vanish, but low-grade inflammation was still quietly smoldering in the background.
Just slowly doing damage.
Right. And that silent inflammation slowly destroys the intestinal wall. It eventually leads to fibrotic strictures, the need for major bowel resections, and, a significantly heightened risk of colon cancer.
So making the patient feel better is really just clearing the smoke. It doesn't mean the fire is out at all.
Which led to the modern paradigm shift in the field called treat to target. Today, the actual medical target is mucosal healing.
Meaning you need physical proof.
We need objective physical proof that the fire is out. We confirm this through a colonoscopy, looking for tissue that physically appears normal and healed. And we look alongside objective stool biomarkers, like fecal calprotectin.
I saw that term in the sources, fecal calprotectin. What exactly is that?
So fecal calprotectin is a protein released by specialized immune cells called neutrophils whenever there's active inflammation in the gut. By measuring it in the stool, we can quantify the fire without doing an invasive procedure every time.
Oh, that's incredibly useful.
It is. Doctors now will adjust or switch medications until those objective markers hit normal levels, regardless of whether the patient says they feel fine.
It's a much more rigorous standard, for sure. And to understand how we actually achieve that level of deep tissue healing today, we have to look back. We have to trace the pharmacology back to its origins.
Which is quite a story.
Because the very first fire extinguisher used for this wasn't even designed for the gut.
No, it wasn't. You're referring to sulfasalazine, which has, honestly, one of the most ironic origin stories in modern medicine.
The history here is just fascinating. So we're in the 1930s, and there's this Swedish physician at the Karolinska Institute named Nana Svarts, and she's trying to find a treatment for rheumatoid arthritis.
Right, joint inflammation.
Yeah. And at the time, a prevailing medical theory was that rheumatoid arthritis was actually caused by a bacterial infection that just sort of settled in the connective tissue.
Which we now know is totally incorrect.
Right. But operating on that theory, she decides to engineer a dual-action drug. She takes a common antibacterial, links it to an anti-inflammatory compound called 5-ASA, and she bonds them together using this chemical bridge known as an azo bond.
Her goal being to kill the theoretical bacteria and calm the joint inflammation all at once.
Exactly. So how did it do for arthritis?
As an arthritis treatment, it was a massive disappointment. I mean, it barely had any effect on the joints at all.
But, and this is where it gets amazing, doctors started noticing something strange. When they prescribed this failed arthritis drug to patients who happened to also suffer from ulcerative colitis, just by pure coincidence, their gut symptoms vanished.
Yeah, they inadvertently cured a severe bowel disease while aiming at the joints. It's wild.
What's fascinating here is the mechanism, because the mechanics of how this works weren't fully understood until decades later, right?
No, they had no idea at the time. But the brilliance of sulfasalazine, and really the entire class of modern 5-ASA drugs like mesalamine that eventually evolved from it, lies entirely in its chemical delivery system.
Because it's not working the way normal pills work.
Right. It does not work systemically by absorbing into the bloodstream. It works locally. It acts almost like a topical soothing cream applied directly to the inflamed gut lining.
Here's where it gets really interesting to me. If it works locally, like a cream, how do you swallow a pill and get it all the way down to the colon without the body just absorbing it right away?
That is the big hurdle.
Yeah, because if you take a normal anti-inflammatory, the harsh acid in your stomach or the massive absorptive surface of your small intestine is going to break it down almost immediately.
And that is where Nana Svarts' azobond comes in. That chemical bridge acts as a form of molecular armor. It is incredibly resilient.
So it just powers through the stomach acid.
It easily survives the acidic environment of the stomach, and it resists absorption in the small intestine.
Yeah.
The molecule just travels completely intact all the way down into the colon.
So it's essentially a Trojan horse.
Exactly. And the mechanism that finally opens the Trojan horse is bacterial.
Wait, really?
Yeah. The human colon is home to a massive, dense population of gut microbiota. Certain strains of these local colonic bacteria produce specific enzymes called azoreductases. When the armored drug reaches the colon, those bacterial enzymes physically cleave the azo bond. The armor falls apart, and the active anti-inflammatory 5-ASA is released in high concentrations right onto the inflamed colonic tissue.
That is wild. It's a targeted delivery system triggered by the local environment.
The bacteria themselves trigger their own fire extinguisher. It's incredible engineering, even if it was totally accidental.
But knowing this mechanism, knowing that the drug only activates in the colon, it brings up a huge discrepancy in the clinical history. Because if it works so well for colitis, why did our sources say it's basically useless for Crohn's?
Well, remember what we said earlier about Crohn's disease? It frequently strikes the small intestine, specifically the terminal ileum.
Which is anatomically before the colon.
Right, so if a Crohn's patient takes this drug, the pill stays armored through the small intestine. It literally bypasses the exact area where the Crohn's inflammation is raging.
It's like sending a fire truck straight past the burning house because the driver is under strict orders to only stop at the end of the street.
That is exactly what happens. That anatomical mismatch is a glaring flaw. The active drug simply doesn't deploy where it's needed most in many Crohn's patients.
Which makes sense.
And yet this highlights one of the most stubborn controversies we found in the sources. For over 40 years, doctors routinely prescribed 5-ASA drugs to patients with Crohn's disease anyway.
I mean, why would they prescribe a localized drug for a disease that's in the wrong location? Especially when systematic reviews, like those Cochrane analyses we look through, repeatedly showed that 5-ASAs perform essentially no better than a placebo for Crohn's.
It really comes down to clinical momentum and, honestly, the fear of alternatives.
What do you mean?
For a very long time, 5-ASAs were the only relatively safe option available. They have an exceptionally mild side effect profile. They're essentially topical aspirin for the gut.
Okay, so doctors felt safe using them.
Right. If the only other tools in a doctor's bag were highly toxic systemic steroids or a surgical bowel resection, they felt compelled to offer something mild first. Even when the anatomical and clinical data proved it was ineffective for Crohn's, the habit just persisted.
Wow. It shows how deeply clinical inertia can become entrenched in medical practice.
It really does. Clinical momentum can totally outlast the evidence.
So if a localized smart bomb, like a 5-ASA, fundamentally misses the target for Crohn's or, just isn't powerful enough for severe ulcerative colitis, you need a totally different strategy.
You can't rely on local delivery anymore.
Right. You need to put the fire out from the inside, systemically, like a systemic sprinkler system. This brings us to the biologic revolution, which, surprisingly, also borrows its origin story from rheumatology, just like sulfasalazine.
The parallels are striking, aren't they?
Yeah.
So in the early 1990s, researchers Mark Feldman and Ravinder Maini were studying the immune pathways of rheumatoid arthritis, and they were looking at cytokines.
Which are what, exactly?
Cytokines are essentially the chemical messenger proteins that immune cells use to communicate with each other. They discovered that one specific cytokine tumor necrosis factor alpha, or TNF-alpha, was acting as the master regulator of the inflammatory cascade.
It was like the general giving the orders for the immune system to attack the tissue. So the logic is if you can neutralize the general, you stop the entire army.
Precisely. To do that, pharmaceutical scientists engineered a monoclonal antibody designed to hunt down and bind to TNF-alpha in the bloodstream, silencing its signal. This drug was called infliximab.
Okay.
And in 1997, a gastroenterologist named Stephen Targan realized that Crohn's disease was driven by a very similar inflammatory pathway. So he ran a landmark clinical trial giving infliximab to severe Crohn's patients who had failed every other therapy.
And the results were just mind-blowing. They redefined the whole field. Patients achieved a level of deep tissue healing that the medical community had never seen before.
It was a total game changer.
Infliximab was approved in 1998, becoming the very first biologic therapy for any gastrointestinal disease. But, and if we connect this to the bigger picture, introducing lab-engineered proteins into the human body comes with a massive counterintuitive risk.
It does. The dark side of this was the architecture of the drug itself. Early biologics like infliximab were chimeric antibodies.
Meaning they were kind of a hybrid?
Yeah.
Yeah.
Because of the limitations in genetic engineering at the time, the drug was constructed using about 75% human protein sequences and 25% mouse protein sequences.
Wait, mouse DNA. So you are injecting a massive complex protein into a patient's bloodstream, and their highly sensitized immune system scans it and realizes it contains mouse parts.
Yep. It recognizes the medicine as a foreign pathogen. The immune system reacts to the biologic the exact same way it reacts to a virus. It builds specific anti-drug antibodies to neutralize the invader.
Man.
This is a phenomenon known as immunogenicity. Clinically, a patient might experience a miraculous recovery, achieving full mucosal healing for a year. Then suddenly, the symptoms come roaring back.
Okay, wait, I want to bust a major misconception here. So if a patient is on a biologic and gets sick again, it doesn't mean their Crohn's is mutating into some kind of super disease, right?
Oh, not at all.
Yeah.
It's a terrifying experience for a patient. But it is critical to understand that the disease itself hasn't necessarily progressed or gotten worse.
It's just the body rejecting the drug?
The failure is entirely pharmacokinetic. The patient's immune system simply became highly efficient at chewing up and destroying the medication before it could reach the gut. The drug is just eliminated from the bloodstream.
Wow.
That is why modern protocol dictates that before abandoning a therapy, doctors draw blood to measure the concentration of the drug and check for the presence of those anti-drug antibodies.
Which sets up one of the most significant clinical trials in this space. The 2010 SONIC trial.
Yes, a massive turning point.
Because the fundamental problem was the patient's body attacking the life-saving drug. And the solution they tested in the SONIC trial sounds incredibly radical.
It really does.
Yeah.
The SONIC trial hypothesized that you could protect the biologic by deliberately suppressing the patient's overall immune system.
That sounds dangerous.
Well, they took patients and gave them infliximab, but they also gave them an older, broad-spectrum immunomodulator drug called azathioprine.
Okay.
Azathioprine blunts the rapid division of immune cells. The goal wasn't just to use two drugs to fight the Crohn's. The goal was to use the azathioprine to suppress the immune system, just enough to prevent the body from forming anti-drug antibodies against the infliximab.
It's essentially hiring a chemical bodyguard to protect the primary drug from the patient's own immune defenses.
That's a perfect way to describe it.
And looking at the data, it worked, right?
Yeah.
The patients on this combination therapy beat monotherapy. They maintained much higher, more stable blood levels of the biologic, and their rates of healing were vastly superior.
It completely altered the standard of care for high-risk patients, but it also highlighted a severe limitation. Azathioprine is a blunt instrument. When you suppress the immune system broadly enough to stop it from building antibodies, you are also suppressing its ability to fight off everyday infections, viruses, and even certain cancers.
You're lowering the shields of the entire body, which forces the question, how do you target the disease without leaving the whole body defenseless?
That challenge led researchers to investigate a completely different mechanism of action. Instead of trying to neutralize the cytokines like TNF-alpha, what if we just physically prevented the immune cells from traveling into the gut tissue in the first place?
Right, changing the strategy.
This led to the development of anti-integrin therapies.
I love this concept. The mechanics of how immune cells travel are fascinating. Let's say your bloodstream is an interstate highway, and the white blood cells are the cars patrolling the road.
Good.
Integrins are specific adhesion molecules on the surface of the blood vessels. They basically function as highway off-ramps. When a white blood cell is needed in a specific organ, it binds to the corresponding integrin and exits the bloodstream into the tissue. So an anti-integrin drug works by closing the highway exits. Instead of putting out the fire, you're just blocking the arsonists from taking the off-ramp into the tissue.
Taking that analogy further, if you close the off-ramp, the inflammatory cells just keep circulating in the bloodstream indefinitely. They are entirely unable to enter the gut tissue to cause damage.
It's a really elegant solution.
It is. However, the first major attempt to utilize this mechanism ended in a profound tragedy.
Yeah, let's talk about that because it's sobering.
In the mid-2000s, a drug called natalizumab was introduced. It targeted an integrin called alpha-4.
But alpha-4 wasn't just an off-ramp for the gastrointestinal tract, was it?
No. Alpha-4 is widely expressed across multiple systems, most critically in the central nervous system. It is the primary off-ramp that immune cells use to enter the brain and provide routine immune surveillance.
Oh, wow. So by blocking alpha-4 globally, they accidentally boarded up the doors to the central nervous system.
Which left the brain completely unprotected. Shortly after the drug was approved, patients began developing a condition called progressive multifocal leukoencephalopathy, or PML.
Which is a brain infection, right?
Yes, it is an extremely rare, devastating, and frequently fatal brain infection. It's caused by the JC virus. Now, the JC virus is a common, usually harmless virus that a massive portion of the human population already carries.
But our immune system normally keeps it in check.
Exactly. A functioning immune system keeps it entirely suppressed. But without immune cells patrolling the brain, the JC virus reactivated and destroyed the white matter.
It is the ultimate cautionary tale in pharmacology. You try to cure a devastating gut disease, and because the targeting wasn't specific enough, you strip away the brain's defenses.
It was a massive failure of target specificity. Natalizumab was immediately pulled from the market for IBD.
It's a dark moment.
It was, but it catalyzed a massive leap forward in molecular engineering. Scientists realized they needed a target that was fundamentally unique to the gut.
So how did they fix it?
They analyzed the adhesion molecules again and found that immune cells traveling specifically to the intestines rely on a very specific subunit combination, the alpha-4 beta-7 integrin.
Ah, so the beta-7 subunit is the key.
Exactly. That specific combination is expressed almost exclusively in the GI tract. It is heavily gut selective. Researchers engineered a new biologic called vedolizumab that only binds to the alpha-4 beta-7 combination.
That's the redemption story right there.
Yeah, it successfully closes the off-ramps into the gut, extinguishing the IBD fire, while leaving the immune surveillance of the brain, the lungs, and the rest of the body completely intact. The risk of PML basically dropped to zero.
That level of target specificity, like blocking a single molecular doorway while leaving the rest of the building open, is staggering.
It really is an incredible achievement.
But now that we have these incredibly powerful, highly precise tools, it totally changes the strategic conversation. The question isn't just how the drugs work anymore, but when a patient should actually get access to them.
This raises an important question, and it brings us to a major clinical debate that has really fractured the gastroenterology community. It's the step-up approach. versus the top-down approach.
Yeah, let's look at that. The traditional dogma has always been step up. You diagnose a patient, and you start with the mildest, cheapest, safest drugs available. You try the 5 ASAs.
Right.
If those fail, you step up to a short course of steroids. If that fails, you try an immunomodulator like azathioprine. And only after the patient has failed multiple classes of drugs over several years do you finally pull out the big guns, the biologics.
That's been the standard for a long time.
But honestly, knowing that Crohn's is actively destroying the bowel wall, making a newly diagnosed patient jump through hoops with weaker drugs that might fail, seems fundamentally backwards.
Yeah.
If biologics can achieve mucosal healing and prevent permanent bowel damage, why make them wait? The fire is burning the whole time.
You're pointing out the exact ethical and physiological flaw of the step-up approach for aggressive disease. In 2008, a landmark clinical trial led by Geert Dines was published in The Lancet, and it challenged the step-up dogma directly.
What did they find?
The trial demonstrated that forcing high-risk Crohn's patients to fail conventional therapies allows irreversible tissue damage to accumulate. Once fibrotic scar tissue and strictures form, no drug in the world can dissolve them. Surgery becomes inevitable.
So you have to hit it hard early.
Yes. The top-down philosophy argues that we must introduce highly effective biologics immediately upon diagnosis for high-risk patients. The goal is to achieve deep mucosal healing before the permanent structural damage ever occurs.
It reframes biologics entirely. They aren't a last-ditch effort for end-stage patients. They are a tool to prevent a patient from ever reaching the end stage.
Exactly.
Which also neatly dismantles a major myth about these treatments for the listener. A lot of people view 5 ASAs and biologics as basically interchangeable, like choosing between ibuprofen and a stronger prescription painkiller.
Oh, they operate in entirely different realms of pharmacology. Biologics are not interchangeable with 5 ASAs.
Because of how they act on the body.
Right. 5 ASAs provide local symptom relief and can maintain remission in milder ulcerative colitis, but they do not alter the fundamental trajectory of the immune system. Biologics are disease-modifying agents. They actively interfere with the core mechanisms of the autoimmune response, physically changing the long-term course of the disease.
And speaking of therapies that shouldn't be relied on long-term, we have to mention steroids, like prednisone. There's still a lingering perception that relying on a low dose of steroids to keep IBD in check is an acceptable maintenance strategy.
Corticosteroids are incredibly powerful at knocking down acute severe inflammation quickly. If a patient is hospitalized in a massive flare, steroids are a vital bridge therapy. But they are blunt, highly toxic instruments.
They are definitely not a long-term plan.
Never. Extended use leads to devastating systemic side effects: irreversible bone density loss, adrenal gland suppression, cataracts, and a severe susceptibility to infection. Today, a successful clinical outcome is explicitly defined as steroid-free remission. If a patient requires ongoing steroids to function, their current maintenance therapy is failing.
So, synthesizing everything we've looked at today, what does this all mean for you, the listener? Beyond the fact that IBD affects millions of people globally, often striking seemingly healthy people in their teens and 20s, this specific corner of pharmacology represents the frontier of modern medicine and economics.
The economic impact alone is profound. Biologics are complex proteins cultivated in living cells. You don't just mix them in a chemical vat like older pills.
They're extremely expensive to make.
That manufacturing complexity means a single infusion can cost thousands of dollars, placing massive strain on healthcare systems. What we are witnessing right now is a critical rollout of biosimilars, which function similarly to generic versions of biologics.
To try and bring the cost down.
Exactly. Global markets are watching intensely to see if biosimilars can inject enough competition to drive down these staggering costs and increase patient access worldwide.
And the scientific implications are just as massive. The journey from the tragic failure of natalizumab to the triumph of the gut-selective vedolizumab created the exact blueprint for precision immunology.
It really did. Researchers are now applying these exact lessons to engineer highly targeted organ-specific biologics for other devastating autoimmune conditions like lupus, multiple sclerosis, and psoriasis.
We are finally moving away from the era of suppressing the entire immune system with a sledgehammer. We are learning how to negotiate with specific cellular pathways at a molecular level. It's incredible to trace the line from nanosparts chemically gluing 2 pills together in the 1930s to today, where we are selectively closing molecular highway exits.
That's been an amazing journey to cover.
But as we comb through this data, there's one final, undeniable trend that really forces you to step back. The incidence of IBD is rising at a staggering rate in newly industrializing nations across the globe.
Yes, the epidemiological data is very clear on that.
And researchers overwhelmingly link this explosion in cases to the rapid adoption of Western dietary patterns, ultra-processed foods, and the resulting radical shifts in our gut microbiomes.
It is a critical observation
Yeah.
because the human genome hasn't mutated over the last 50 years, but our internal environment, driven by our external environment, has fundamentally transformed.
So here's a final thought to leave you with, to mull over on your own. We have spent this entire deep dive exploring the brilliant, highly complex pharmaceutical fire extinguishers we've built to put out these flames. But if our modern environment, our processed diets, our depleted soil, and our altered microbiomes are the things actively striking the matches and confusing our immune systems in the first place, well, could the ultimate treatment of the future bypass pharmacology altogether?
It's a fascinating question.
If we can identify the environmental trigger, perhaps the next great revolution in disease modification won't be engineered in a multi-million-dollar laboratory. Perhaps it will start on our dinner plates and in our soil.